Okay, the live stream is on now, so if you want to start, we're good to go.
Well, hello, everyone. Welcome. I'm going to go ahead and get started. Thank you for joining us for today's event. We are co-sponsoring with the League of Women Voters of Seattle-King County. We are going to be discussing the proposed King County property tax levy to fund mental health and behavioral health services. We'll hear from officials and county representatives, as well as experts in the field to get more information and hear their views on the proposal. I'm Michelle Bruchman, and I'm a reporter at the Seattle Times. I'm working on our new mental health team. This project launched in the fall of 2021 with myself, 2 other reporters, and a team editor. Our mission is to investigate systems of care for mental health throughout Washington, to destigmatize mental health and receiving treatment, to provide a platform for people to talk about mental health, and to provide resources to help people help themselves. Right now in Washington, someone experiencing a mental or behavioral health crisis has to navigate a complex labyrinth of systems to get help. Often, people end up in emergency rooms or jails. The special election on April 25th gives voters the opportunity to decide whether to fund the construction and operation of 5 new 24/7 crisis centers in King County, where people could get immediate and appropriate care. The proposal splits the county into 4 regions, with 1 crisis center planned in each. A 5th center would serve youth. People experiencing a mental or behavioral health crisis, or those under the influence of substances, could walk themselves into any of the crisis centers. They could also be taken in by police, EMTs, mobile crisis teams, friends, or family. Residents could visit any of the facilities regardless of where or whether they live in King County. The centers can bill private insurance, Medicaid, or provide care using levy funds in cases where someone does not have insurance. Together, the King County centers would be expected to serve about 50,000 people per year. The levy would be set at 14.5 cents per $1,000 of assessed home value, so the average homeowner in King County could expect to pay about $121 more annually in their property taxes. The first 2 crisis centers are slated to open in 2026, and the final facility would be expected to open in 2030. However, the levy could support immediate investments in supportive housing programs and money toward existing mental health facilities starting next year. There is no formalized opposition to this campaign that we are aware of. A statement in the voter's guide argues that the levy increases the already high tax burden amount that property owners pay in Washington. We did reach out to a contact person for the group to participate in this panel, but they did not respond. If you want to read stories about the levy proposal and all of our team's work, you can go to st.news/mental health, and we'll also be dropping some of those links in the chat below. As a reminder, for those who are not able to attend the live event, a recording will be uploaded to seattletimes.com afterward. If you have questions, please use the Q&A function, not the chat. We'll be looking through your questions and asking some in the latter portion of the discussion. Closed captioning will be provided on screen as well. Some quick announcements about other areas of our coverage. We run a regular column written by people in the community about a variety of mental health topics. If you'd like to share your experiences navigating the mental health system, or are interested in writing a personal essay, please get in touch with us at mentalhealth@seattletimes.com. And if you'd like to download a brochure with more information about how to help someone in a crisis, you can do so at st.news/crisis brochure. That's one word. We'd also like to extend a special welcome to 28 students participating in the University of Washington's master's program in social work. Thank you for joining the forum. Now let's dig in. Here to do that with me are 4 experts in the field. First, we have Michelle Conley. She's the Director of Integrated Care at REACH. She focuses on providing long-term intensive care for people who have experiences with the traumas of incarceration, homelessness, and intergenerational poverty. Leo Floor is the Director of the King County Department of Community and Human Services. He oversees countywide behavioral health investments, crisis system outreach and engagement, affordable housing production, youth development, and developmental disabilities programs. Next, we have Maggie Hosnick. She's the Director of Clinical Services at the Downtown Emergency Services Center, or DESC. She has spent her career working in outpatient behavioral health and crisis services settings and is currently overseeing the work being done, serving the most vulnerable community members in King County. And finally, we have Councilmember Girmay Zahalai. He's a King County Council member representing District 2. He has worked to build affordable homes for communities experiencing displacement, created treatment centers for neighbors in behavioral health crises, invested more in youth opportunities, expanded public transit options, reformed the criminal legal system, and made the political process more inclusive across communities and generations. Now we're going to start with some questions. So to kick us off, I'm going to start with you, Leo. So among all of the options that exist on the continuum of care for mental health, why has the county chosen to focus on crisis centers? What gap does this fill, and what does it leave open?
Yeah, two reasons. First, if we take a look at this whole continuum, while I would argue that we don't have enough mental health capacity at any part of the continuum, there is one place where we have nothing. So we have some sort of preventative upstream screening type interventions that are available. And then we have quite a bit actually that's focused on the really involuntary or deepest end of the system. But what we don't have is what somebody would need if they wanted to go to treatment right now. There's not a single place that you could walk into right now. So that's the gap that we're trying to fill with the 5 crisis care centers. And then the other piece that we propose that this levy would be able to fill is the fact that we've actually lost capacity in that longer term residential treatment part of the system. And so as the Seattle Times has reported, we've lost 1/3 of the available mental health residential treatment beds in just the last 5 years. And that we just see really starkly in our community right now. So the levy, in terms of the facilities that it would create if voters approve it, is really aimed at those 2 gaps. The other part of your question, though, that I think is important is this levy would not solve all of the problems in the behavioral health system. So what it would do is increase the relative level of investment in crisis care that is voluntary. That level of investment would still be less than the overall investment in the primary care part of the system. And then I think we still need to take a look as a community at how much investment capacity we need across the whole system and how we build the workforce that can support it.
Thank you. And can you tell us how the county came to the number 5 for the number of facilities to create?
Yeah. So when we talk about crisis system access in human services, we're often thinking in terms of what's the overall need and then how many beds or rooms or units might you need to fulfill it. When we talk about crisis care, I think a better regime is really access. How fast is something accessible? And so we achieve that through geographic dispersion. So what we did is divide the county into 4 major sections and say that we at least need in every quadrant of the county one place where somebody could walk themselves in so that they have that geographic access. And that looks a lot more like fire services or first aid responses, where you really want the response time is what you're after, as opposed to the overall number of beds perfectly matching the need.
Gotcha. Okay, so it sounds like access is a part of that decision. Gotcha. So Maggie, I'm going to turn to you. Some voters may see these crisis centers as sort of just another place where a revolving door of the same people will be dropped off. In your experience, have you seen the same people frequently? And then maybe Leo afterward, is that something that you would want to prevent?
Sure. So DESC runs the Crisis Solution Center, and it was developed out of the need to divert people from ERs and jails. And we do see recidivism at the center. People don't go into crisis overnight. The things that lead to the crisis: substance use, untreated mental illness, complicated by homelessness for many. And so it does take some time to undo that and to get people on the path of recovery. And what complicates things is that folks that are unhoused or the most marginalized in our community are not treated well. And so they have a distrust of social services. So it takes some time to engage them, for them to start trusting the staff, to understand how their mental illness or their substance use is impacting their lives. There are communities that experience mental health and substance use different than somebody accessing services in an outpatient behavioral health setting. So there's a lot of rapport building and trust building that goes into somebody latching on to their own recovery. And so that takes some time. I also would say that, so at the Crisis Solution Center, there's 72 hours to stabilize, which would be similar to what the Crisis Care Levy is suggesting, where people can walk in to mental health care. At the Crisis Solution Center, we receive our referrals from first responders and our mobile crisis team. So fire, police, county designated crisis responders, and our mobile crisis team. And once they get stabilized, they can go on to intensive case management. And that means they can sometimes get an assessment to go to treatment if they're ready, or they can get linkages in the community to mental health, physical health care, that kind of thing. But if you come in to the center and you're unhoused, 17 days isn't gonna solve the homelessness problem. So we are often discharging people back to the streets as they are stabilized. And so, you can imagine, you go out, you're stabilized, you're starting to think about your recovery, and then you are given a tent and a sleeping bag and sent back out into the community. And people often go back into crisis because they're going back to survival mode. It's very stressful to be on the street, to be living, without shelter. So hopefully that answers your question.
Yeah, I mean, I do just want to kind of follow up with you there. I think that is a point that, Leo did just reference, but, the idea that people might be discharged back to the streets and that there is, that the crisis centers might serve as that kind of initial stabilizing period, but that afterward people might still return to the streets. Do you have any thoughts about maybe how to address that would be happening?
Yeah, our community needs to make major investments in permanent supportive housing, affordable housing. We need places for people to go. And, honestly, that is the long term, that is the solution. That's what we want to aim for. Now, this system has been broken for decades, and it's going to take some time for us to, to get organized and to start working together in a way that is going to be streamlined. So when somebody leaves a crisis care center, the hope is that there's some step down, whether it's an outreach program that can help people get into housing, or follow somebody until they do get into housing, permanent supportive or market rate. So that is a gap in the service or in the system. And that is also, if we could, do it all over again, we would want to develop something like that.
Gotcha. So it sounded like you were saying that maybe there should be an expectation that for people who have been in serious crisis, especially for a while, that they might take multiple trips into a crisis center.
Oh, yeah.
So Leo, is that something that the county has kind of built in as an expectation, or is that something they would want to reduce in terms of recidivism?
Well, absolutely. I think a really important thing to understand about the Crisis Solution Center, which I think provides an essential service in the community, is that you have to wait until somebody calls the cops or an ambulance to even be eligible to get referred in there. What crisis care centers would do is to move that point of eligibility further back into the experience of crisis. And so just like with medical care, the earlier in the course of the issue that you receive the care, the better the prognosis is. And so as we take a look at what a functional crisis system can and should look like, we want to be able to move the point of access to the initial point of crisis, and ideally have fewer people waiting until the cops get called, fewer people waiting until an ambulance needs to come. The other point that I think is important is when we take a look at all of the people who experience mental health issues, concerns inside of our community, the vast majority of them are housed. The vast majority of them are not experiencing homelessness. And so certainly homelessness is something that would cause a person to experience, or could cause a person to experience a behavioral health crisis. But these facilities would be available to anyone in the community. And as the person who oversees the part of the system that is the entry door into the involuntary system, we see that we go to the richest communities and the poorest communities across King County to provide that crisis intervention at the involuntary stage. And I would expect that experience of crisis to be sort of similarly represented on the full socioeconomic spectrum across the county.
And just to stay with you, Leo, we know that people would be able to walk themselves into the centers to get care, that these would be voluntary. But are people going to be committed involuntarily while at these centers, or taken involuntarily to these centers? How will that process work?
So right now, we actually have places in the system where you could go if you were involuntarily detained. They exist in our community. They're called evaluation treatment centers, ENTs in the language. Right now, those facilities actually turn away 26% of the people who are referred to them for various reasons. But these crisis care centers are set up to be voluntary facilities. So they would not be the place where you would go if you were involuntarily detained. They do have, the definition requires that there be designated crisis responders on site, and those are the people who can do the initial determination for involuntary detention. But again, the purpose here is actually to reduce the number of people who are going into the involuntary system by intervening earlier in the crisis, and recognizing that for some people, involuntary detention is going to be necessary. We just think that's a much smaller number than we currently are seeing. But if you create all of the continuum being able to be accessed in one place, a crisis care center, then this just becomes a much more efficient and effective way for clinicians to be able to make the decision. This person requires short-term care. This person requires involuntary treatment, or we want to refer them for that kind of assessment. But all of the options are on the table instead of just one option.
And just to stay with you there on that, will there be an expansion of the number of designated crisis responders at any point, given that we know that there's high need for them?
Yeah, so you mentioned high need. Factually, right now, if you from the community called for a designated crisis responder, which unfortunately is closer to the front door of our system than the back door that it really should be, you'd wait on average 270 hours for that a designated crisis responder to respond within the community, which is a very long time relative to how crises tend to occur inside of a family or a household. So we believe that we may need to increase, at least in the short term, the number of designated crisis responders locations. So they would be at each of the 5 crisis care centers. But once you have people able to go someplace, we actually believe that we're going to have a lower need overall for designated crisis responders to go out in the community. And that may actually end up with a lower number of teams necessary, even though the number of locations could increase.
Okay. So will there be protocols for disciplinary actions if they are needed? So if someone who is in crisis comes into the crisis center, Leo, will people be barred if they become aggressive in some way? Can they return? Is there any exclusionary list that will be, maintained?
So the ballot measure ordinance would require that a crisis care center endeavor to serve every person who seeks care there. All illegal or dangerous activity, is illegal or dangerous activity. So if somebody shows up and presented a risk of serious physical harm the kind of thing you'd normally, call 911 for because it's unsafe. That certainly still happens, in behavioral health centers now and homelessness shelters and affordable housing. But the idea is that if that risk of violence is attributable to crisis in behavioral health conditions, let's bring them in, let's stabilize them, let's put them into a situation where we're able to assess what's going on, put them in contact with peers who can do a ton to sort of de-escalate the situation, get them in front of clinicians who are trained in interventions that can actually help people achieve a level of stability that you can then talk about treatment as opposed to talking about whether a person should be punished or barred.
Gotcha. And Maggie, I'm wondering, have you ever seen a need for expelling someone for violent behavior towards staff?
So this is an interesting question, especially, when somebody is in crisis. Thank you, Leo, for, pointing out when you are in crisis, you're at your worst, you're having your worst day. And so it is really on the staff to be trained in crisis de-escalation and being able to talk to people and really connect quickly. And that's, one of the reasons why peers are so powerful in these environments. Folks with lived experience, maybe they've been to a center like this, they can share their success and also be with somebody that's fearful. But how we handle it is we don't have rules and we don't punish, but we do have expectations. It is a treatment facility. It is a recovery community, and that's how we frame it. And so there are things that would lead to somebody being asked to leave after after we have talked and worked with them. And so an example would be somebody maybe has posturing and is throwing chairs or something like that. We will take them, we'll de-escalate, we'll take them aside and just, human to human, what went wrong there? What can we learn from this? We don't want you to do this, but if you do continue this, we might have to look at asking you to leave. But what that means in our environment is we'll find you a place to go. We don't just turn people back to the streets. We help them through this. And through this process, being consistent and showing up for people and being genuine and, restoring humanity, people want to be in these centers and they know that their help, they can get the help they need. So over time, if they return, you stop seeing those behaviors.
So it sounds like staff are trained to know how to de-escalate those situations. In the event that they become violent, aggressive in some way. What does helping someone find somewhere to go if they're not able to stay look like in practice?
Yeah, well, it's been changing. So the center's been open for over 10 years. We're going on our 11th year. And so in the system, we had, prior to COVID, we had shelters where people could go, you could refer them, and the shelters would take folks, they would make room. Sometimes, if somebody has an escalation or there's something related to their behavioral health, they need a higher level of care. And for us, that means hospitalization. So we do talk, with people about voluntary, and at times we do have to involuntarily place somebody in the hospital to protect them. Family, friends, returning, going to family, friends.
Are there ever situations where 911 is called?
It doesn't happen as often as you would think, but yes, of course. And we have developed a relationship with the police precinct in our area that if we are calling, it's because we really need them. And the emphasis then is on training our staff how to escalate, how to kind of contain any kind of violent behavior.
Gotcha. So I'd like to ask now about discharge plans. Michelle, in your experience, what have you seen as effective for transitioning people from hospitalization to outpatient care?
Yeah, thank you. I think the most critical thing is to start the discharge planning upon a person's arrival to a facility, even if that is, any institution, jail, hospitals, crisis centers, and that intervention of whatever that institution might be offering is only going to be as effective as the discharge plan. And so I think that's really critical to keep in mind when developing plans for a coordinated crisis system. What we see at Reach, we serve people who are experiencing homelessness, who use substances and are typically unsheltered, chronically unsheltered. It's really important for us to build rapport and to be with people, do warm handoffs, connecting people, meeting them at the facility at point of discharge earlier, but certainly at point of discharge, providing them support and accompaniment to follow-up appointments, from whatever their goals may be, engaging with them and offering support to connect to all of the following goals that they might have. So yeah, I think discharge planning is a critical component. I think also there are ways for those who do cycle through these systems to talk about what did we learn from that, and then what are the warning signs for before entering into those facilities the next time, so that we can actually think about pre-crisis. Right now, we really don't have a lot of places for people to go, particularly people who use substances, who use substances, live outside. We don't have physical spaces for them to go. And so it's really critical right now that we realize that reality. We talk with our clients about, when they are elevating to a place of crisis, what can we do to help you stay safe given your reality? What would you like to see in a world? So, tapping into the voices of people who are experiencing this right now around what they want to see in a facility such as this.
And Gurmai or Leo, could you share what the discharge planning is going to look like?
That's definitely a Leo question.
Yeah, I'm happy to jump in. So again, this is, I think, where it's important to recognize the full diversity of who experiences crises and therefore would need to go to a crisis care center. So for a lot of people, the care plan will look like stabilize, perhaps connect you to ongoing treatment, and then send you back home. But maybe back home with some additional tools that you have to identify the signs of crisis, to perhaps have a better connection or follow-up appointments with follow-on treatment providers. In other cases, again, it's important to remember that the Levy not only would seek to construct crisis centers, but long-term mental health residential facilities that we've lost in our community. So for some folks, they would transition to longer-term care facilities. And we do have the state making investments to build up some of those facilities in the community as well. And then for folks who don't have a home, it is true that this levy doesn't solve homelessness. But even for folks who are going to be living in shelters or unsheltered, discharge planning can look a lot like here is a follow-up appointment or next day appointment. Here's a connection to a case manager. Let's perhaps get you induced on medications that can help with opioid use disorder. So there's a lot of intervention that we can make. And in some ways, it's analogous to an emergency room. The purpose of a crisis care center is to get at that immediate experience of crisis, provide you with some connections and tools to maintain a more stable condition. And then, that plays a really important role, but it's not the only role. So discharge planning, which is an eligible expenditure of the levy as it's presented to voters, is something that is a smaller part of what we would be able to invest in, but is not the major feature.
So after 23 hours at a crisis center, could someone still stay there longer, or would they be at that point transferred to a different facility?
Important question. One, the answer is going to be a clinician making the decision. And I think that is an important facet of creating these types of facilities. Every crisis care center will have a 24/7 walk-in behavioral health urgent care, so anyone could go in any time of day. As you mentioned, there'll be a 23-hour facility on site that's really meant to help with observation and stabilization. There will also be a 14-day what's called crisis stabilization unit on site, so some folks would be able to stay within that crisis stabilization unit. And for folks who need that sort of intermediate term of care, that's a lot more time where you can then come up with the plan, make a connection to a follow-on facility if it's available. So there won't be any ability to stay beyond 14 days. That's the time limit of the longest term component of the crisis care center itself.
And so it sounds like after 14 days, at that point, staff would help find that person a longer term place to stay if they were still needing care. Okay.
Absolutely, with the important caveat that there are not enough places right now for people, particularly people who come into crisis while they're unhoused or unstably housed. That underlying crisis is still true, and so this levy would not get at solving that.
What do you think would be needed to get at solving that?
Yeah, it's really outside the scope of this particular proposal. A lot of people have actually studied this and published the studies on it, but depending on who you ask, we are either 40,000 over 4 years or 112,000 over 20 years of units of housing behind in our community. That gap is growing. And so if we want to get at the question of how does everyone have a home that they can afford, we need to construct as a community tens of thousands of housing units. And I sometimes, as we considered the proposal just as a factual matter, we don't put it on the behavioral health system to solve the community's housing crisis.
Gotcha. So, Michelle, back to you. As we all know, we're facing a shortage of behavioral health workers. Do you think that the proposals in the levy will be enough to attract workers when that's been such a big obstacle throughout this pandemic and afterward?
Yeah, I mean, I appreciate the emphasis on workforce stabilization. I've heard of the proposal to increase wages for these facilities, 20% higher than average is maybe what the quote is. I could be wrong on that, but I think we already face challenges in securing a workforce and retaining workforce because of the nature of a nonprofit. We can't compete with city and county wages. And so I think we have to be thoughtful as a community. Yes, we need to develop a robust crisis response, and we need to staff that. And if that is the most resourced space, it will increase the number of people in crisis, because that's where people can go to get what they need. So we need an equal investment in the services that do crisis prevention work. And I think it would be helpful for us to, provide evaluation and studies and reports to the community around what are the programs in our community right now that are doing that crisis prevention, and how can we uplift that workforce and invest in that workforce and incentivize people to stay in those workplaces as well.
So knowing that the part of the proposal is increasing wages, Leo, how will the county prevent that increase in wages impacting other counties and states? So, maybe people leaving other parts of Washington to come to King County for those increased wages, and then sort of creating a cascading domino effect where then there become deserts in those parts of the state, or from other kinds of mental health systems of care. So, nursing facilities or long-term care or other parts of the system. How will these increased wages impact those other states or facilities?
Yeah, I think it's a really important question. The levy is constructed and includes in its eligible expenditures not just wage enhancement for the crisis care centers, but also significant investments in growing the workforce, attracting more people. The levy term is that we need to make the workforce more sustainable and representative. And so it would be able to invest in things like apprenticeships, And then interestingly, it mentions things like reducing insurance costs for providers, or perhaps supplementing childcare fees for providers, or paying for or compensating for the fees and tuition for people to be trained to do this work. As to the salary, there is a lot of work going on around this exact issue across the nation. And I think what everyone agrees that we have seen, or at least all the studies that I have seen, is the answer is not to suppress wage growth in order to prevent people from moving around. We're going to have to make investments in the workforce to allow people to do this work long enough to attain mastery and make a career of it. Behavioral health care work in particular is a particularly human enterprise and concern. I think the council member, has a really good take on this and the value of workforce, but what I have seen, keeping the wages low as a factual matter is not going to help the system at all.
And Gurmai, do you want to share some thoughts that you've had on how to strengthen the workforce?
Yeah, I just echo everything that Leo said. It's not only increasing wages, which is an integral part of it, but also building out the pipeline so that this is a career that people choose, and we grow the workforce itself in addition to how much people are being paid.
Can you share a little bit more about what some of these workforce development programs are going to look like? There have been some questions, including from some of the master's students watching, about what those apprenticeship programs are going to entail.
Yeah, so I can, this is a place where there are existing strategies or programs within the community, and that's one of the first places we would look, should voters approve the levy, to then put into an implementation plan that the King County Council would have to pass that would allow for deployment of the funds. But there's, for example, right now, between a set of labor unions and the University of Washington's Behavioral Health Institute, an apprenticeship program that has 3 courses of recruiting people into the field so they could become a certified peer counselor, for example. And then making that both affordable but also visible. Not a lot of people intuitively know how to get into the behavioral health field. So even if you wanted to do this work, it's hard to find your way into it before you get to the question of how you can afford it. So I think apprenticeships really are an important component to growing the workforce, whether or not we're talking about this levy. The other thing is deferring the costs. So people who might want to switch careers, for example, or start with this career, in many ways, it can become cost prohibitive if you don't have the ability to afford the initial certification. And so I think the public, what we can do from the government perspective is to lower that barrier to entry so that people can get into the field and not incur so much debt that they can't afford to continue doing the work because of the wages that the field pays.
And just to clarify, will peers, people with lived experience, will they be part of the staff of these crisis centers?
So the ballot measure has one section that addresses this specifically, and it says that any crisis care center must have a multidisciplinary team of staff that must include peers, or shall include peers. So peers are actually the only particular sort of professional category that are specifically named by the ballot measure ordinance.
So we know that a lot of the details will be worked out in an implementation plan to be passed by the King County Council. But, given that information, we know that there's going to be a crisis center in one of the 4 geographic regions in King County. But Gurmai, could you share a little bit more about, what the county is thinking in terms of siting, or maybe why it hasn't laid out specifically where these centers are going to go, knowing that property values continue to increase and buying might get more expensive?
Yeah, this is a question that's come up a lot, which is, why doesn't the implementation plan come first and be baked into the levy that goes out? And I see a couple of reasons for that. Number one, it takes a lot of community engagement and resources and staff power and tax dollars to do that kind of in-depth implementation plan. And do you want to do all of that and then potentially have the levy fail and you expended a lot of resources to do something that didn't come to fruition. That's one consideration. The other consideration is the more details you put into the levy, the more prescriptive it is, the less discretion and flexibility you have as circumstances change. And so you can imagine that if you are all the way down into the exact address of every crisis care center and you put that on the ballot and then something happens with that location, now you legally cannot cite this building anywhere else. And that is not something that you want to be in. So you have to find the right balance. But I do disagree with this idea that some people have been putting out that, you know, the levy is vague or anything like that. I think this is one of the most prescriptive, most detailed levies I've ever seen. You know, it lays out exactly how the money will be spent across various different buckets. It even gives geographic designations. And there are also certain crisis care centers that exist today in some portion of what they ultimately will be. So in other words, there are some crisis care centers that don't exist at all, and we're going to have to go out and construct them in one of these geographic zones from scratch. But there are others that already exist in that zone, but they don't have all of the components to make them a full service crisis care center yet. And so it would be developing them so that they do become that full service center that we're describing.
So it sounds like you're saying the county doesn't want to tie itself to a specific location legally and then be bound to that if circumstances change.
You can imagine how much work it takes to do citing, right? You know, you have to engage the local councils, you have to engage the local neighborhoods. Sometimes local neighborhoods come out and say, don't put this here. That happens a lot. And so if you're legally bound to put something in one place by the levy ordinance, and then are issues with that citing, then you would have all these resources that you can't use for that address. So it's a trade-off.
Are there any locations in the central region of King County that you think might be a good fit for one of these centers that you'd be willing to share?
That's a question for Leo. Leo, can you think of anywhere in Seattle that you would consider a crisis care center in part or in full at this time?
Yeah, happy to jump in. So the four zones, you know, you've got what we call East King County, North King County, South King County, and then the central zone that you're asking about is the city of Seattle and its adjacent unincorporated areas plus Vashon Island. So that's what constitutes the central area. I think zoning is important here. So zoning, first of all, sort of constrains where a facility like this can be cited in the first place, and that reflects where cities largely have decided different types of uses should be determined by land. What we're going to be likely looking for, although I think it's really important again to say here that this is something that has to go into the implementation plan and then be approved by the King County Council, is things like geographic access. So again, how is a location someplace where a lot of people will have access to it? We're going to be looking at proximity to other services that will be useful or helpful. So you wouldn't want to put it in a place that's completely isolated from any other type of service, such that if somebody needed to be referred to a medical hospital for a particular condition, for example, that you have a really or unreasonably long way to go. And then it's also going to matter where they sort of sit relative to each other. So you wouldn't want all of them in a line, sort of all the way up and down just one side of the county, and then you don't have access in the other zones or on the far ends of other zones. So I don't have a specific site in the central zone that we are looking at, and we don't have a list of sites where we're saying, this is the place that it should go. We are going to be working with the cities within each of the crisis response zones, and those cities and providers working within them will nominate or apply for the citing of these facilities, and the county will review those applications and then make decisions based on some of the factors that I've described.
Gotcha. So Gurmai, you were saying that the levy that you've seen as proposed is very prescriptive. And, indeed, it does list out how much money is going to be allocated for support services or the restoration of the beds or administrative fees or capital costs or operating fees. But, I guess what happens if the money for capital costs doesn't end up being enough? If, some of these facilities are cited and the county ends up needing more money to make these happen?
First, I will hope that our state government is going to continue a push toward making these investments. There have been a lot of questions that I've gotten about why isn't the state doing this? And from my view, the state and the federal government have absolutely abdicated their responsibilities in this field. They've been defunding recovery infrastructure for decades, and they're leaving local governments to address these problems through imperfect tools like property taxes, sales taxes, taxes that really burden middle income and low income people. And that's by design, by the way. The county government doesn't have any other tools. We've gotten questions like, why doesn't the county tax the rich or tax big corporations disproportionately and fund it that? We just can't. The state doesn't allow us to in the state constitution. And so what would happen if the cost of construction continues to escalate the way it has been? We've been in that situation before where we're planning to build something and then the cost of construction goes way beyond what was projected. And so in that situation, we would just have to reassess, build what we can with existing funds and then collaborate with other levels of government to see if we can bring in more investment to complete the picture.
And Michelle, I saw your head nodding as Gurmai was talking. Is there anything you want to add, especially in regard to the state responsibility?
No, nothing to add.
Okay. So, I guess on that same note, what are the plans after year 9 of the levy to continue operations or continue funding operations? Once these are open and people start using them and get used to them, what are the plans to provide funding following that year 9 for either Gurmai or Leo?
I'll add one thing and I'll pass it to Leo. Part of the strategy is definitely being reimbursed by Medicaid. If people are low income or seniors and they qualify for those federal programs, the county is what's called the pass-through entity for a lot of these funds. So a lot of the operational services could be covered by the federal government. And then in terms of more capital costs, I would hope that we wouldn't need as many capital costs to maintain and continue these centers as we do at the outset, which is why we have so many capital costs to build in the first place. But down the line, hopefully it wouldn't be as much. But we would definitely need state partnerships, federal partnerships in that realm as well. Leo?
Yeah, just to build on that. So the way that the levy is proposed right now, there would be a substantial amount of capital construction, which is a one-time cost, which is different from capital maintenance. The types of costs that would go on beyond the 9-year term would be the staffing and operations costs, and then the maintenance costs for the facility. When we take a look at the operations costs, what we have done is take a look actually at the Crisis Solutions Center that Maggie works at, and we looked at how much of their current operations are Medicaid reimbursable. We then took a sort of conservative cut on that and then modeled operations costs. And we are assuming right now that Medicaid would reimburse 20% of the total costs of operations for a crisis care center. There are bills in front of the legislature right now, and that would seek to begin making more types of care and reimbursable, and then elevating the rate of reimbursement for those. So a lot of the work would be working with the state to expand what is reimbursable and the rate of reimbursement. And we know that that's possible because other states actually have much more robust reimbursement regimes for similar crisis facilities that make them nearly sustainable without just on Medicaid. We then can factor in the fact that again, a lot of folks who will be seeking crisis care, and I can't, predict the particular percentage here in King County, have private insurance. And so one of the requirements is the ability to bill private insurance when that is available. And so that would be a source of quote unquote revenue for the facilities to make them sustainable over the long term. And then the third thing, and it gets at some of the questions that are in the chat, is if somebody comes from out of the county, we have the ability to bill through Medicaid for people whose point of origin is another, what we call region. In fact, we do that right now on the primary care side for behavioral health. It's got the unfortunate name of leakage and reverse leakage in Medicaid reimbursement terms, but we have the ability to do that now. So all of those would build us to a more sustainable operations budget. But I think it's really important. There's no world in which we would want to not fund maintenance of facilities on an ongoing basis. Another of the questions in the chat is, why are we in a situation where so much of our mental health residential capacity has actually left and one of the big or lost in the community? One of the big reasons, as we can see, is initial investments in building things and then no investments in maintaining them. And then the facilities all reach their useful life or the end of their useful life at about the same time. And that's why we're seeing so many of them sort of leave the system right now.
So, I mean, Leo just answered, a lot of that question of what else the state could do, but I want to turn it back to you, Gurmai. What else do you think the state should be responsible for? And then maybe to that end, what do you think should be the federal responsibility and maybe the responsibility at the county and city level?
Well, there was an article actually in the Seattle Times, I think that was shared in the chat, that asked the question, where did all of King County's mental health beds go? And a big theme that you see is partially what Leo is talking about, which is an initial capital investment from state or federal government, and then not enough maintenance to keep those buildings operational for the long term. They reach their life cycles, they close out. And then the federal and state government have been responsible for a lot of privatization, relying on small nonprofits to do this kind of work and then not reimbursing them, not funding them properly to continue doing that work. And so you see so many nonprofits that are stretched thin, staff who are being paid poverty wages to do some of the most difficult work known to human beings. When in reality, we need the state and the federal government to step up much more, both in terms of investing in the nonprofits that they are initially relying on, but also toward creating state-sponsored facilities themselves and operating them themselves as well. And so that's what I would like to see happening. Because they could create statewide network where we wouldn't have these concerns about, who's coming from which county to where, burdening King County, burdening Pierce County, because it would be a statewide network. And also they just have more tools for raising revenue. People are sick of property taxes. I keep hearing this from our constituents. And when they say that to me, I say, you are absolutely right. You are absolutely right. This is not a scenario where I'm coming in saying, oh, $10 a month is not that much. No, it's actually significant, especially for seniors and people who are on fixed incomes on top of all the other taxes that they're paying. It's a lot of money. And for us at the county, we're constantly being put in this dilemma by the state where we have these competing public interests of, do we solve pressing problems like the behavioral health crisis? Or do we avoid raising regressive revenues that disproportionately impact lower income, senior people on fixed incomes? And that's an impossible decision to make. It's a constant battle that we're having to choose. And the state by design has put us in this dilemma, because if we just go with avoiding property taxes, then we have no resources or not enough resources to address the big problems. If we keep addressing the big problems, then we're harming people who are on fixed incomes and being taxed out of their home and creating a whole nother issue with people not being able to afford their home anymore. It's a very unfortunate situation, and the state and the federal government could solve that pretty quickly if they had the political will to do that.
So it sounds like your answer to people who are upset about, property taxes continuing to rise for some people to an unsustainable level is, I hear you. And is there a world in which this could have been funded through a means other than a property tax, a business tax? Someone said a hotel tax. Are there other ways in which this could have been funded? Maybe grants, or money from the opioid settlements? Could they have been used? Was there any way to build these centers without funding them through a property tax?
Not by the county. Not by the county. When we think about the scale of how much it costs to build things in a region that has one of the highest costs of construction in the world, when we think about how the complete dearth or lack of facilities like the ones that we're trying to build in our region and how big the scale of the problem is to be solved, the price tag on that is very is steep. We're in the billions now, and there's no scenario where the county could rely on the opioid settlement, for example, which would bring to King County a couple of $1 million, or through grants even. We will accept grants if the federal government wants to step up or the state government wants to step up and give more grants to the county to do this kind of work at the scale that is needed to build and operate and address these huge problems. We would absolutely accept that and prefer that.
Maggie and Michelle, I want to bring you in. Is there anything you want to add in terms of state responsibility, or just acknowledging the financial responsibility that will be taken?
I don't think I want to. I don't have anything to comment that way, but I do want to piggyback off of what Leo was talking about with Medicaid and private insurance, and how at the Crisis Solution Center over the years we've figured out how to glean some Medicaid, but we've done that kind of behind the scenes. So our direct line workers do not have to be burdened by the administration of that. They, so they can spend time with the clients and doing what they're supposed to do. And King County has been a wonderful partner in that. Is what we, how it works basically is you send up the encounters to King County, they match them with who's eligible for Medicaid, and maybe with the, I don't know how it will work when the crisis care centers come in, if private insurance wants to bill, but if the counties, or if the county can continue to do that, that is just an amazing gift to the crisis centers. And I am every day so grateful that we get to work with the folks that come in and not be burdened by the billing.
Michelle, I should also point out, to add to what I was saying before, that this property tax levy is eligible for low-income people, senior people, and veterans to qualify for property tax relief and exemptions.
Okay, so if you are of a certain age or a certain status, you can apply for a reduction in the cost.
Correct.
Okay. So everyone who is watching, I have one more question to ask our panelists, and then we will start to take some audience questions. We're going to try to get to as many as we can before we close out. So make sure you use the Q&A function to ask your questions, and we'll get to them in just a moment. So the last question, is going back to something that Girmay, you had said earlier that I wanted to return to. This idea that mental health facilities can often run up against opposition from people wary of having them in their neighborhoods. So how does the county try to sell the levy to residents who maybe don't want a crisis center next door to them?
This levy and the idea behind it of crisis care centers has been so different in terms of my experience with what neighborhoods and different cities want. Whereas citing, shelters and things like that can usually be a fraught process. I've actually been hearing people battling to get this in their neighborhoods. People are saying, please bring this here. We need this. I think people understand the scale of the problem, and they're seeing what happens when there is an absence of infrastructure like this. And so we've actually been seeing really, really high demand for it. Leo, has that been your experience as well?
Yeah, what I can say, I'm often the guy who shows up when we're citing permanent supportive housing or shelter. And so I know very well that dynamic. We obviously have not at the county attempted to set a crisis care center yet. The city of Kirkland, with 4 other cities, though, did recently open up a facility that's very much like what we are proposing for a crisis care center, and does not appear to have experienced any opposition. So, from my perspective in an official county seat, I don't think I can, try to predict one way or the other what the experience will be like. But we do have a larger coalition of community members who have supported the proposal, and the one similar facility that has opened didn't appear to have any sort of meaningful or widespread opposition. And so I think factually, those are 2 things that I observed.
Gotcha. So it sounds like you're saying you're not hearing much opposition from people. People are not seeming to push back on the idea of having a crisis center near them.
I mean, what the thing that we do hear about is, why isn't there, what I hear about routinely is, why does it take so long to get care in a crisis? Why does it take so long to get into treatment when somebody wants it? Why does somebody have to sit in supportive housing or housing of their own for days or weeks instead of being able to get access to the behavioral health care that we know works? I think that's another thing that we hear quite a bit is, people understand that people recover. People understand that behavioral health care is a medical process by which evidence-based practices can be applied to people with particular conditions to improve their health. It's not something that is not scientifically based. It's not something that we think works. Treatment works when it's available at the right time, in the right amount, to the right people in the right place. And we just lack those facilities in our community right now.
And Gurmai, you mentioned community engagement. Should the levy pass, what would that process look like?
Yeah, Leo has done a lot of implementation plans before, so I'm sure he'll have a more formal answer. But I would think it would be engaging the different zones to see where each crisis care center would be built, working with the city councils in each zone, working with the mayors in each zone, working with the service providers, and designing an RFP so that we can find out who the correct service providers would be to fulfill the needs in each crisis care center. And also engaging the community, people who are impacted by these issues, and seeing how can we best serve you? How can we best structure the physical layout of the building? How can we best structure the suite of services that are offered there to best serve the people who are the intended end recipients of this?
Thank you all. I'm now going to turn our attention to some audience questions that have coming in. We've received, I think, over 100 different questions. So we're going to try to get to as many as we can. And thank you all for submitting such smart, thoughtful questions. So we've had a number of people express concerns that King County taxpayers would be on the hook for paying for these services when they would be open to anyone in the state, really anyone in the nation, including people who weren't residents of King County. So how would you respond to those concerns? And I'm just going to throw this open to whoever wants to respond first.
Yeah, I can jump in with just some of the factual background and then leave any other piece of the response to others. But right now, crisis facilities like this actually exist in Pierce County and Spokane County. So if that phenomenon is real, where people will go to other places, they're coming from us to those other places right now. Now, I've not heard from Spokane or Pierce County that they are receiving a large influx of King County residents to those two facilities that I'm mentioning. I think what we do see is that instead of people coming from far to receive care in particular places, that people are just not getting care. I think that's what we see. The other piece of it, though, that I did mention is we do have this back-end billing, which is super, nerdy on some level because it gets into Medicaid billing practices. But if somebody's Medicaid eligible, which is the vast majority of people whose income is below a certain level, we have the ability to, with their name and some basic personal information, understand what region of the state their Medicaid cost is attributed to. And then we work with those other regions to recover that cost. So that's the two sort of factual pieces to the answer that I have.
Gotcha. So I was also wondering, could you, share a little bit more of the proposed oversight for these centers so that, people know that they're actually getting the help that they need? What will the kind of accountability oversight look like?
Yeah, so first, centers, facilities like this are licensed facilities, either by the Department of Health primarily at the state level. So crisis stabilization unit, for example, what that is and how it must function and the license that it has is actually a feature of state law. And so it would be overseen at that licensure level, just like any other medical or behavioral health facility currently is in the state. The county would be the contract holder to the providers. So one thing that we haven't covered is that the county would not itself staff and operate these facilities except for the designated crisis responders, but it would be providers. And so through contract, they would have performance measures and the providers are required to fulfill their performance measures. And if they're not, they can go on things like performance improvement plans. But the vast majority of the time, what we see is that they're able to fulfill their performance measures. And then the Levy ballot measure ordinance also contains a provision for an advisory committee that would be made up of a combination of residents of the county, so not necessarily people from the government, but people who have experienced behavioral health crises themselves, who come together in an advisory committee, and they would be able to provide advice and review of the performance of the overall system, and then give that advice to the King County Executive and to the King County Council to influence how we might through contracting, seek performance improvement or amplify successful practices that we see at some of the centers.
And now, would one contractor be responsible for operating all 5 of the centers, or would there be potentially 5 different contracts?
So each center could potentially be operated by one provider or a partnership of providers. So again, we listed 4 sort of necessary elements of a crisis care center, but it's possible that you could have one provider that does the behavioral health urgent care, but another provider doing the crisis stabilization unit for 14 days, for example. So you could have multiple providers on one site, and then each site would be separately procured or RFP'd in county language. So it is possible that you could have the same provider for all sites. It is also possible, and I think more likely, that you would have multiple providers across those sites. But I can't answer it factually until, 1, we see what happens with the levy, and then 2, we'd have to see what applications come in.
Understood. So one of the questions that came in, people want to know about the differences potentially between the youth-focused crisis center and the adult crisis centers. Are there going to be any meaningful differences between them other than just the age that they're serving?
Yeah, we have some clinicians on the line, and so I'd certainly defer to them on some of the specifics here. But the way I would think about it is, if you go to Seattle Children's versus Harborview, those are very different types of facilities and environments that sort of befit the types of folks, the ages of the folks that they're seeking to serve. But more than just aesthetics, there are sometimes different licensure requirements. There are certainly different specializations. It's the difference between a general practice physician and a pediatrician. So there is a lot of sort of evidence-based specific practice that we know works for youth versus working for adults. And the purpose of a youth-focused facility is to make sure that we have one place where we've got that youth-focused, behavioral health practice, youth-focused types of facilities that becomes attractive to youth and their families who are experiencing crisis, so that it's a place that they'll go.
And Michelle and Maggie, is there anything you'd like to add?
I think Leo covered it, and I'm learning a lot from the county council member too.
Great.
Yeah.
So, one of our next questions, we know that this is not the first time that this model is being created. So are there examples where this model has been established and has a record of success?
I took a trip to Arizona last year that was organized by Senator Dingra and Representative Tina Orwell. And by the way, while I'm blasting the state as I have been, there are definitely multiple champions individually at the state level, like those two, who have been doing incredible work. And some of the work that they did was taking a coalition of elected officials to Arizona to study a state that has established national best practices around behavioral health. And that is the model that Leo has taught me about many times, which is the three-pronged system of somebody to call, somebody to show up, and somewhere to go. And so that's what they do down in Arizona. And I think that's what we're trying to solve for here, which is somebody to call. That would be the 988 phone line that people are now establishing at the state level, where you can get crisis care services over the phone by a trained professional. And if those services are not enough to stabilize you, then you have a mobile crisis response unit come and show up on site and provide you care on site wherever you are. And if that's not enough to stabilize you, then you have somewhere to go, which is the physical locations of a crisis care center, hopefully up to 14 days of service until you are up and ready to go. And of course, you need the full continuum. So if 14 days is not enough, maybe you need one of these long-term residential health beds that we are trying to build back the capacity for. Maybe your next stop is a permanent supportive housing. Maybe your next stop is a hospital to treat, more physical maladies that you might have. And so we definitely need to build out the continuum, but these best practices exist elsewhere already.
Yeah, just to amplify what the council member mentioned, this is a model that exists in other places and is actually being promulgated as a best practice at the federal level. So, anybody can get on a computer right now and Google crisis system SAMHSA, and you'll find a number of guides that list a bunch of examples of what a crisis system should have inside of a community. So Arizona is a place that we have certainly been in contact with. I mentioned that there are actually other facilities in Washington. So if you go to Pierce County or Spokane County, they have similar facilities. Ohio, California, Kansas, these types of facilities actually exist in many places, but they don't exist right now in King County.
So we've heard some questions in the chat about whether there would be a lot of people who would be going to these services voluntarily. There are people with serious mental illness that may not recognize that they are ill. My colleague Esme Jimenez wrote about the concept of anosognosia, that people can't always recognize their own illness. So how have you seen that play out with other crisis centers here or elsewhere?
Yeah, we have the benefit of seeing some of these other crisis centers that I've mentioned in other locations. And so none of the ones that we have done a direct comparison to are first involuntarily detaining somebody and then sending them. So the company that would be operating the one that is sort of coming forward in Kirkland, for example, estimates that they'll have between 10 and 14,000 people per year utilizing that facility, and that's based on the usage that they're seeing in other facilities that they have. So one, just empirically, we know that people use the facilities. Two, I think we're going to have to, what we have trained ourselves in our community for, and this is just sort of a factual description of what we currently have, because we don't have access to crisis facilities that are available earlier in the experience of crisis, we have trained ourselves as a community to not know what to do when we see the first signs. We know that somebody's not going to be able to walk right into treatment right now. And so in some ways, we have trained ourselves as a community right now to wait until we think somebody poses such a risk of harm to themselves or others that they would trigger the very high, appropriately very high bar of involuntary detention. And that is our response in large part to crisis right now. So I think as the community gets used to the fact that you could just walk into a place and get care, that we would see changed behavior. And we can look at the medical system analog for another, I think, data point. Urgent cares are profitable enough that there are several of them run by for-profit companies, just around where I live. And that's been a point of observation for us, that medical care, urgent cares are prolific at this point because people do want to go get care or take their family members to go get care before it reaches a point of crisis. And that's another data point that has us considering the fact that crisis care facilities could be similarly well used.
We're seeing lots of great questions, and we are trying to get to as many as possible. So some people have asked, we understand the way in which this is the costs of mental health are being kind of laid out through the levy and allocated those funds toward. But are there theoretical savings by keeping people out of emergency rooms and out of jails? And how can we kind of conceptualize that and see those funds reinvested in these centers? And again, open to whoever wants to answer.
Yeah, on a factual basis, we have a couple of places where we do track cost savings in the behavioral health system. And what we're often comparing that to is the cost of jail or the cost of emergency room use. And so the most expensive place a person can be is a medical emergency room. The second most expensive place a person can be right now is jail. And then we often compare that to like a housing or community-based setting, which is cheaper. So the types of intervention have different levels of cost. I think a really important thing though is you can't realize savings from the existing system until you build the thing that would replace it. And so you do have to build the alternative before there's a chance at realizing any savings from the other system first. And then a thing that we just hear a lot about is cost can be measured multiple ways. And certainly there is financial cost and that matters, but there are other types of cost to asking people to wait until the point of crisis or incarceration to get care. And we certainly see that in the community right now.
Yeah, just to add on to that, the strain on our systems is incalculable. Yes, the human toll on an individual basis is devastating, and just the system-wide toll. If we're talking about our jails right now, our jails are in a really, really bad place. Incarcerated people are suffering because of these issues. Jail staff are suffering, having to sleep in the jails and work multiple shifts every day just to keep the jails operating. And part of that is because there are a whole bunch of people in there that should not be in there. They need a different type of environment. The last estimate I got is that there are about 100 people in the jail who the state has a legal obligation to remove from King County's jail because they are not deemed to be competent to stand trial. So there was a court case called True Blood, which said if somebody is deemed to not be competent to stand trial, within 7 days, the state is supposed to come, remove them from that jail setting, and provide restoration services. And they're not doing that, partially because the behavioral health capacity system-wide is so low. That's what they're telling us. But what does that do to the people who are suffering in the jail, who should not be there? What does that do to the people who have to staff a jail that is overloaded with types of issues that they're not set up for? What does that do to our systems where now we're having to deal with overloaded jails? And what does that do for public safety? What does that do for emergency rooms? What does that do for our public transit systems, which are being weighed down because of the addiction crisis. I constantly hear from people saying, oh my goodness, we're seeing people overdose at bus stops and overdose in the transit. So all of the systems that you can think about where we have to keep moving as a region are being weighed down because of this behavioral health crisis. And so it's hard to measure that in dollars and cents, but I imagine it is far, far greater than what's being asked for in the levy.
So I think we have time for 2, maybe 3 more questions to squeeze in. So, just in terms of the practical operation of these, how would the crisis centers interact with emergency calls from both 911 and 988? Would calls that would normally be sent to police be rerouted so that person would go to a crisis center instead of a jail, or instead of interacting with police? What would that look like?
Yeah, Councilmember Zahala, I sort of laid out the overall concept that any functional crisis system, you need a person to call or to talk to, somebody to respond, and then a place to go. So as we do make investments at the state level and nationally in a 988 call, that's an alternative to 911 response. And then we make investments in mobile crisis teams and even co-responder models that embed behavioral health professionals with law enforcement. The piece that we are now lacking in King County is that place to go that's not a jail or an emergency room. So one way that this works is you call 988, the mobile crisis team responds and then can take you to a crisis care center. Another way that it could work is you call 911, law enforcement or a firefighter shows up, make a determination that this is a behavioral health issue instead of a criminal or fire safety issue. They call a mobile crisis team, and the mobile crisis team can then transport somebody to a crisis care center. And then a third way that it can work, and this is just where you're calling, providers to take you there, is that a law enforcement officer could actually transport a person to a crisis care center instead of to a jail or to an emergency room. They take a lot of folks to emergency rooms right now, and they can do that. They have an authority as a peace officer to transport somebody to a triage facility or a care facility when they think that person poses a risk of harm to themselves, but it doesn't have to end in incarceration. It can instead end in treatment.
And now, we haven't talked a whole lot about what going to a crisis center is actually like. What would you experience if you walked in one? And maybe Maggie and Michelle, if you want to start here.
Sure, I can speak from the perspective of the Crisis Solution Center. So the referents are first responders, ER social workers, and what somebody might experience is they come to our front door. We do what we call a soft handoff, make sure that that the person that escorts the individual in is explaining what it is. We take basically over the care, send the first responder back into the community to do their job. And then we have 3-hour triage. And during that time, we are meeting basic needs and letting people rest. We do a psychiatric assessment and a social work assessment based on, kind of what people want to do in that moment. It's pretty simple. And then they are assigned to a space that is their own, and they can sleep or have something to eat. But those first 72 hours are pretty important to just stabilize somebody. I always think that if I was in crisis, what would I need? And I would want to curl up in bed. I would want something to eat, and I would want somebody to care for me. And that's exactly what these, the front end of the crisis centers do. Yeah.
I'll just add too that I think touching on what the council member mentioned and Maggie, I think what's important to note about this development of a policy alternative, a response or development of something that's new in our community, that we racially stratify our systems, and folks of color will go to jail, white folks get routed toward crisis centers. And when we see people have, existing criminal histories, We often see those routing toward legal system when there is actually a mental health crisis at play, or a crisis induced by something else. So we really need to be proactive in monitoring the utilization and referral to respond to the communities most impacted by the drivers of crisis. Right now, what we're seeing in our community, converging crises of homelessness and overdose and incarceration. So I just want us to be thoughtful of that, to ensure that these centers serve all communities in a way that is equitable, and that the workforce is representative of the people who are coming to those spaces, not peers, but also like culturally representative, and being responsive and welcoming, and creating an environment that is, culturally appropriate and responsive.
So on that note, we have just a few minutes left. I just want each of you, if you want, to go around, and if there's any, final words or any questions that didn't get asked, but you want to, share or respond to, you can take this time to do so. So I'll start with you, Michelle.
Yeah, I think crisis response doesn't solve the problem, doesn't solve the problem of everything that we're seeing on our streets, but it is critical, it's necessary, we're long overdue. There are many indicators that our community is in distress. From my viewpoint, working on the streets and supporting teams who do outreach to people on the streets in crisis. We have to look at the accelerating and intensifying rates of homelessness, look at the rising level of fatal drug overdose. We have this kind of return to war on drugs, war on poor mentality, and emphasis on incarceration. We have to work on the front end and respond to these crises that we're seeing, and have thoughtful mental health responsive systems that incorporate a substance use lens as well, and have no wrong door for engaging people who also have substance use issues. We also need to look at our architecture of our mental health system overall and invest in spaces, invest in housing that is preventative of crisis, and look at the impact for people who are experiencing poverty, especially when people are in desperation. There's a higher rate of crisis when people can't meet their basic needs. So an investment upfront will do us good as we also build out what is critically necessary now with these crisis systems.
Thank you. And I'll go to Maggie next.
Great, thank you. I guess what I want to say is there's not one size fits all, right? There's different ways of addressing crisis, and we need those different ways. It has been a system that needs to expand and needs to build off of what has been built over, the last few decades. And we just need to forge a new pathway.
Thank you. And now Councilmember Zahalai.
Thank you. I want to echo something Michelle said, which is that it's so important to remember that the behavioral health crisis and homelessness are not the same thing, right? The vast majority of people who are in mental health crisis, the vast majority of people who are overdosing, they're doing so in their homes. And so I hope people are not interpreting this levy as a cure for homelessness. It's not a cure for homelessness. These issues are very intersectional, of course, they're very connected, but people should not go into this thinking that this is going to be the thing that solves our homelessness crisis. That's going to be making sure that we build 40,000 units of homes with corresponding supportive services in the next 4 years, as Leo mentioned, and those numbers, of course, there are different ways of interpreting those numbers. And we should also keep in mind the scale of this problem. This levy by itself is not going to cure the behavioral health crisis either. We're still going to need a lot of investment from our federal government, a lot of investment from our state, a lot of coordination from every level of government, private sector as well. But this is a needed response. This is a needed response. It's definitely part of the framework that we're trying to develop. We want to develop that framework of a phone line to call, somebody to respond and come to you and provide you services on site that is not necessarily a police officer with a gun, and a place for you to go that is not necessarily the emergency room or jail, but instead somewhere that is a therapeutic environment that will allow you to get both immediate stabilizing care and also long-term residential behavioral health care. That's what this levy will provide. In addition to the resources itself, it's also providing a framework, a guide for how the future that we want to build together.
Thank you. And Leo, do you want to close us out?
Yeah, I'm probably the least exciting person here because I'm just factual, but just to answer a sort of string of questions that I did see in the chat. One of the sort of themes of the questions is, isn't the state investing in capacity right now? The state is investing in some capacity right now. So last year there was $16 million in King County that was, for new behavioral health facilities. As a factual matter, we have less behavioral health residential capacity now than we did 5 years ago. And we are, I believe, going to continue to lose that capacity unless we change the pattern of investment. That doesn't necessarily have to be through a levy, but we are not seeing that change in pattern of investment in facilities right now. And that's why we have fewer facilities and less capacity now than we did 5 years ago.
Thank you. So thank you all for your time today. Thanks to the audience for attending and for submitting smart, insightful questions. And thank you to the panelists for giving your time to talk with us and share your expertise. As a reminder, if you have any questions or story ideas, you can email our team at mentalhealth@seattlettimes.com, and a recording will be available on seattlettimes.com. And now I'm going to turn it back over to Mary Taylor, who is the first vice president at the League of Women Voters.
Sorry about that. Oh, geez. Having trouble. I'm so sorry. It keeps going back to closing out my video. There we are. Okay. Well, I have nothing exciting to say except thank you to everyone, our panelists and our partner in this endeavor, the Seattle Times Mental Health Project, and also to the audience for attending and submitting such great questions. And I also want to note that the League is a nonprofit, nonpartisan political organization that encourages active participation in government. League works to increase understanding of major public policy issues like this one and influences public policy through education and advocacy. We are a volunteer, member-driven grassroots organization, and we rely on contributions to continue to produce events such as this one. So please visit the League of Women Voters, Seattle King County website, and either join the League and contribute, maybe both. Also, I want to note that we will send a link to the YouTube video to all those that registered, and also all of the links that appeared in the chat throughout the event. So we'll get that out as soon as we can. And thanks again to everyone. Good night.
Thank you. Good night.